Ready?
Yep.
Okay. All right. Today we're going to talk about ABG interpretation, and I'm going to show you a very quick and simple way to learn how to read them. We're going to go from simple to complex. In other words, from uncompensated to partially compensated to fully compensated. And I'm going to show you how to read those. Hopefully all of you in your packets got this lovely little handout, this Rome mnemonic regarding acid-base balance, and we're going to pull that into it. That's a very integral piece. So we'll get started. Acid-base balance is defined as a condition existing when the net rate at which the body produces acid or base equals the net rate at which acid and base are excreted. Arterial blood gases are the way that we analyze acid-base, and this is the best way to evaluate it. Okay. In the ABG reading itself, there are several components, but there are four that you really need to be, well, three that you really need to be astute to. And when I teach this to you here in a second, the ones that are vitally important are your pH, your PCO2, and your bicarbonate. And you need to remember them. Remember to look at them in that order: pH, PCO2, and bicarbonate. When we talk about pH, or partial hydrogen ionization in the body, we're talking about the amount of hydrogen ions, which are positive ions, that are concentrated in body fluids. Now, when we talk about hydrogen ions, we are talking about acids, all right? When we are talking about CO2, we are also talking about acid balance. However, when we combine hydrogen and HCO3, we're talking about bicarbonate, which acts as a buffer or a base. The normal pH, as you remember from your reading, 7.35 to 7.45. You need to know the norms. This is very important. Knowing the norms, without knowing them, you're not going to know whether these are in or out of range. And as we look at the pH, PCO3, O2, I'm sorry, and the bicarbonate, HCO3, you will need to know those, all right? Your PCO2 is, again, your carbon dioxide, the partial pressure of how much carbon dioxide is in the bloodstream at any given moment. The normal for that is 35 to 45 millimeters of mercury. PaO2 was not one of those three that I wanted you to look at, but you still need to have a handle on what that oxygenation of the arterial blood is. If it drops quickly, this is going to give you a very good indication that this could possibly be a respiratory-induced type of issue, okay? So don't rule out that the PO2 is of no or little importance, because it is something that you will need to look at. But for our purposes today, understanding the basics of how to read an arterial blood gas, we're going to be looking at pH, PCO2, and the bicarbonate, your HCO3. The bicarbonate is a renal component. The PaCO2 is a pulmonary component. Those are vitally important issues to remember, because the lungs will kick in when the pH becomes unstable, one way or the other, either acidotic or alkalotic. The lungs are going to kick in first. Respiration will either increase or decrease to either blow off or retain CO2 to bring that pH back to a normal. This acts immediately. Consider choking on a hot dog. Are you hyper or hypoventilatory? You are not ventilating when you are not moving air, so you're hypoventilatory. When we are hypoventilatory, we become very acidotic very quickly, okay? We are retaining CO2, which is an acid, all right? So it's going to make us acidotic, okay? If the lungs cannot compensate, in other words, we don't loosen that hot dog pretty quickly, somebody does the Heimlich, smacks us on the back, flips us over, pounds on us, beats it out of us, and it flies out 50 feet, and we take a nice deep breath and begin to bring that pH back to normal on our own, and it remains lodged there, the EMTs come and get us, and we are now on life support, on a ventilator, fighting for our life, okay, near choking, near death experience. In a couple of days, 2 to 3 days later, if our pH is still ranging in that acidotic area, our bicarbonate or our renal component is going to kick in. Now we know that from anatomy and physiology, the kidney retains hydrogen and potassium and regulates the body system that way. It's actually regulating that pH. So over the long term, this does not kick in right away, this renal component. It will take several days before this does. The lungs kick in initially. Henceforth, this is why when we look at acid-base imbalances, we look at pH first. Tell me if it's acidotic or alkalotic. PCO2, is it a respiratory issue or is it a renal issue? Okay, is it respiratory or is it metabolic? Okay, all right. With that in mind, normal bicarb is 22 to 26 milliequivalents per liter. Okay, those are the normals. There are 4 major types of acid-base imbalance, and we're just going to run through these very, very quickly. Respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. And in your textbook, in your AD textbook, there are charts that kind of pull together what these actually are, the key features of the acidosis and alkalosis. Okay, let's talk about a very common respiratory acidosis first. We see this with hypoventilation, that choking hot dog, okay? We also see it with atelectasis of the lungs, where the lungs have lost their compliance. We see it with pneumonias, where there is no ventilation, there is no perfusion. The lungs are either not compliant to perform ventilation, the mechanism of ventilation, or the mechanics, using our muscles, using the lungs, the intercostals, the diaphragm, or there is no perfusion. There is no perfusion at the alveoli level, at the alveolar level. We see it with cystic fibrosis, another lung disorder with young people. We see it with respiratory failure, ARDS. Generally, we see respiratory failure with any one of these: atelectasis, pneumonia, cystic fibrosis, airway obstruction, that hot dog, that steak. Chest wall injuries, we see it with paralysis. We see hypoventilation with head injuries. We see it with obesity. The sleep apnea that we associate with obesity, and therefore we put people on CPAP and BiPAP. Drug overdoses with opioids, big one, respiratory depression, and paralysis of respiratory muscles, as in like Guillain-Barré. Okay. Our signs and symptoms of acidosis: dizziness, confusion, headache, or of hypoventilation. Warm, flushed skin. These aren't just hypoventilation, but these are signs and symptoms of any one of these disorders over here. We know that the pH is less than 7.35 in acidosis. That arrow points down, doesn't it? The PCO2, however, points up, doesn't it? It's above 45, that normal 35 to 45 millimeter mercury range. And our bicarb will be normal if it's uncompensated or above 26. We'll talk about that. Don't get hung up on that bicarb piece right now. We'll talk about it. With respiratory alkalosis, we are looking at the opposite: hyperventilation, asthmas, pneumonia, ventilator settings when patients are either trached and on mechanical ventilation that are inappropriate and causing them to have higher than normal respiratory rates. They are ventilating more than they need to. Anxiety. You know how we all breathe in the old paper bag? That's still practiced today for anxiety, so you don't pass out, okay? Hypermetabolic states like fever, exercise, hyperthyroidism, disorders of the CNS like head injuries, spinal cord injuries, or infections, meningitis being one of them, salicylate overdoses, aspirin overdoses. We see hyperventilation. Again, we may see signs of dizziness, confusion. We see dysrhythmias, however, with hyperventilation. Tachypnea, numbness, tingling of the extremities, and again, that pH is going to be greater than 7.45. In other words, that arrow is pointing up. The PaCO2 is going to be, and this should actually be below that 35, okay? There should be an arrow pointing down here, below 35, okay? My bad there. And then again, your bicarb may be normal if it is uncompensated, okay? Let's talk a little bit about metabolic. We know that we look at pH, we look at the PCO2. Now we're gonna look at metabolic. We're gonna bring in that bicarb or that renal component, okay? We're a couple, 2-3 days out now, and our pH is still out of whack. It's still not 7.35 to 7.45. It's somewhere on that 7.35 and less end, okay? And the causes for metabolic acidosis: starvation, DKA, diabetic ketoacidosis with our type 1 and type 2 diabetics, especially our type 2s, or type 1s. Renal failure, lactic acidosis from heavy exercise, or a myocardial infarction when the heart stops and the cells no longer are aerobic and respirating. They become anaerobic and they build up lactic acidosis, which fills the bloodstream, causing us to be acidotic. And this is why we give bicarbonate IV during code situations, okay, to kind of bring that pH hopefully back to a normal. Heavy use of drugs, illicit drugs, renal tubular acidosis, as in kidney disorders, and diarrhea, long-standing diarrhea. With metabolic acidosis, the signs and symptoms that you're going to see: headache, lethargy, confusion, dysrhythmias again. You're going to see deep respirations. Diabetic ketoacidosis, as you may or may not know, probably most of you do, is associated with a certain way of breathing. When we become acidotic, we have that fruity odor, and we're spilling ketones into our urine, and we test with the keto sticks for urine to see if we're spilling ketones into the urine. But we're also going to see with that diabetic that's in ketoacidosis, they're going to complain of headache. They're going to be lethargic. Confusion is going to set in. And then they're going to begin to breathe. The respiratory system kicks in. And they have a certain type of respirations that we call Kussmaul's breathing, which are very deep, rapid respirations. And what they're doing is literally blowing off CO2, because there's acid on board. This is when not only do the kidneys kick in, but the lungs have already kicked in. Remember what we said, the lungs kick in immediately. Well, they don't stop when the kidneys kick in 2 days later. They continue. And this is why you get all of these systemic and respiratory types of symptoms, all right? Again, our labs are going to be with that pH, it's acidosis, folks, that arrow is going to be pointing down. Our CO2 is going to be normal because this isn't respiratory. This is metabolic. Remember, this is now a metabolic issue. So we expect to see that our bicarbonate is going to be affected. When that is affected, it is going to be in acidosis below 22. It will be low. Now you're going, okay, how do I know that? We're going to talk about that here in just a little bit. But let me get through metabolic alkalosis first. We see metabolic alkalosis with excessive vomiting. Gastric juices are acidic. When we suction them off with NGs or patients vomit heavily, prolonged gastric suctioning, we lose that gastric acid, and therefore the pH is affected, okay? It's going to become alkalotic. We also see it with hypokalemia, low potassium or high calcium levels, okay? We see it with aldosteronism, excessive aldosterone levels, and we also see it with some steroid and sodium bicarb, a buffer, an alkaline. If we use this excessively, and acids, Tums, things like that, Alka-Seltzer especially, we're going to be seeing probably some metabolic alkalosis in the long run with long-term use. We also see hydrogen ion loss with diuretics. We talked about hydrogen ions being acid. When we lose those, the body becomes alkalotic. We are off in that balance. With alkalosis, again, dizziness, dysrhythmias, well, shoot, numbness and tingling, those all, Maureen, that's almost all of them. Muscle cramping, tetany, because of the hypokalemia, we see the dysrhythmias, specifically ventricular in nature. We also see sometimes hypomagnesemia with it, again causing ventricular dysrhythmias. And then the hypercalcemia, we're going to see that muscle cramping and the tetany, okay? Again, it's alkalosis, so our pH is going to be arrow up, above 7.45. The CO2 is normal. Remember, this is metabolic. But our bicarb will be affected, and the arrow to that is also pointing up, okay? So we're going to talk a little bit about those, and we're going to go through a couple of these during practice time, okay? Our first practice, you have a PaO2 of 80, which is normal. Normal PaO2 runs 80 to 100, and I know we didn't talk about that. A little lower than what you would see with your SaO2 monitors. You know, we like them 90. However, with those long-term chronic lungers, you know, we'll settle for 88, okay? This is arterial, remember that. So 80 to 100 is generally a good place that we want to be arterially. Our SaO2 is 95% with that. So we're looking at a pretty healthy person so far. Uh-oh, this pH is acidotic. So with that, our arrow pointing down, we know that this is acidosis. All right, it's below the 7.35. Next, we look at PCO2. Our PCO2 is above the norm, okay? Our arrow is pointing up. So I have a pH that's low. I have a PCO2 that's up, okay? Those arrows are in direct opposition to each other. Then I look at bicarb level. It's normal. when we are looking at ABGs, we tend to look at